issues, but I think it'll be okay. Okay, so we're going to start the case study now. And because I'm going to be trying to hit on this and some of the big data, I'm going to go fairly quickly. We need a little bit of time to wrap up the day. Within this discussion, I'm going to be talking about a tripartite hybrid model that we built to investigate health and cost intervention trade-offs for diabetic end-stage renal disease here in the province. This is work that I conducted in a broad interdisciplinary team. The main people on this team are listed here. Amy Gao was the primary modeler. Wan Yian did a bunch of work with the hybrid modeling. The work was led by myself and Roland Dick, who's a nephrologist here on campus. For a number of years, he was the head of Department of Medicine here, and for decades now, he's been working to investigate burdens within our province associated with diabetes and diabetic end-stage renal disease, particularly for the Aboriginal peoples, First Nations, and Métis people within our province. This work is broadly linked in with somewhere on the order of 8 or so papers out there in the literature, several of them concentrating more on the diabetic side of things, including papers in the CMAJ, American Journal of Public Health, and elsewhere, and then others more on the renal side specifically. Modeling has been a central unifying sort of component of this work. The work has involved a variety of types of modeling as well as statistical models. So we spent a while building competing risks models and others for this area, but much of the work has been done with dynamic models. And there's been on the order of 5 different dynamic models built to shed light on this project from different angles, 5 or 6 now. And each has contributed to some insights about the process, both from the modeling process, but also from the standpoint of prioritization of data collection, enhancing our ability to interpret data, the historical patterns we see in terms of intervention, evaluation, and in terms of making sense of some of the patterns that we saw in the data. So the modeling is here really been used as a learning tool on an ongoing basis in a way that cuts not just one model, but about 5 or 6 different models of diabetes and diabetes end-stage renal disease. A little bit of background on this. Diabetes is the most common cause for end-stage renal disease in Canada. It's a plurality of cases. It's the single most common cause. And both diabetes and diabetic end-stage renal disease disproportionately burden First Nations people. Many of you are familiar with the fact that diabetes rates as measured by incidence, prevalence, or other measures have been rising within our province. What's less recognized universally is the levels of disparity seen, as well as some additional patterns. So if you see this graph, you'll notice a couple key features, and I want to draw attention to a couple key features related to these prevalence rates shown here. The first is the fact that the rates are generally trending upwards. There's more people developing diabetes over time. The rates in First Nations are much higher than the rates among non-First Nations people by several times. But moreover, while there are disparities in both cases according to sex, the roles are reversed. So in non-First Nations peoples, the males have higher rates of diabetes than the females. It's well known and fairly well understood, having to do with adiposity, patterns of central adiposity, etc. Whereas in First Nations peoples, those roles are reversed. First Nations women have considerably higher rates than First Nations men. a gap that is not appreciably lessened over the time frame. What's particularly striking and sobering and very sad in many ways is the gaps you see in terms of where the burden of illness in terms of diabetes incidence falls in the life course. Among non-First Nations people, diabetes is predominantly a disease of the older age groups. This shows on the x-axis different age groups, and the y-axis number of incident cases for different periods of time. And so as you get here, you get older, and you notice it's predominantly a burden, both in men and women in the older age groups. For First Nations people, most incident cases historically have fallen in the middle years of life. In the 40s is the median, or is the mode, of the distribution. This is very sobering because what it means is that when it comes to complications, individuals who develop diabetes in their 40s have many decades over which they're at risk of developing complications. Complications that include very serious conditions such as diabetic nephropathy, and end-stage kidney disease, as well as things like diabetic retinopathy, heart disease, and other factors. So we have not only higher rates among First Nations, we have them. First Nations people suffer this from this insult earlier in life. What's also sobering is not only the prevalence rate's been going up, but the incidence rates have been also rising over the years for diabetes, but also controlling for diabetes. Among those with diabetes, the risk of developing becoming an incident case of end-stage renal disease have been rising. In other words, First Nations peoples are not only at higher risk of developing diabetes, but higher risk of developing end-stage renal disease given diabetes, and that disparity has increased over time, although more recently it's kind of leveled off. I should note that this data that we're showing here is based on administrative data from the Ministry of Health here that we obtained about a decade ago, and we've been really studying with models as a particularly strong component of our lens. So among First Nations people, not only is diabetes occurring earlier, but accordingly, end-stage renal diagnosis is also occurring earlier, over half a decade earlier, as you can see. And number of new ESRD cases within the different groups fall at different portions of the life group. Now, the life path. Interestingly, and this is something our models helped us make sense of, and somewhat counterintuitive here, the First Nations people do develop end-stage renal disease earlier in life, but the time between diabetes diagnosis and end-stage renal disease diagnosis is longer for First Nations people. So there's a longer time between the two. And models helped us make sense of this, what seemed like a paradox. How is it that if you develop end-stage renal disease earlier, but it's a longer time? Well, a lot of it turns out, has to do with the effects of mortality. That later in life, if you develop diabetes later in life, your mortality rates are higher. It tends to shorten the amount of time, and statistically, until you develop end-stage renal disease. You don't have the luxury of living 40 years, 50 years before developing end-stage renal disease. If you're going to get it, and if you're old when you develop diabetes, you've got to get it soon, or else you might be at risk of mortality. So models helped us make sense of this, as it did many other features of the data. Let's talk a little bit about the treatment modalities that are found here. So within our province, hemodialysis is the most common form of support for diabetic end-stage renal disease patients, but peritoneal dialysis, which doesn't depend on use of external equipment, but rather uses the peritoneal cavity for the dialysis, is used by a growing number of of patients, and it has cost implications associated with that. By contrast, kidney transplants are used for a subset of the people, particularly individuals who are in healthier shape and younger. And this draws on both living donors and cadaveric donors who are deceased. And there's a long waiting list associated both with waiting for the kidney and to some degree for assessment. Now, the costs in this area are very sobering. So on a per year cost, hemodialysis it costs close to $100,000 a year per patient. Very high, steep costs. Peritoneal dialysis, by contrast, costs below $60,000 a year. Kidney transplantation, when it occurs, it can be very expensive up front. So within the first 90 days plus the operations cost, you can have very high costs. Once you throw in the donor costs, for example, you've got a total that's over $100,000. But after that, on a per year basis, you're talking about much lower costs. There are significant costs associated with immunosuppressant drugs to keep your body from rejecting the kidney, but they're far smaller than the cost for dialysis. So there's this upfront hit, and then subsequently lower costs associated with transplantation. So, and very importantly, the survival associated with transplantation on a per year basis is much higher than for dialysis. So the model goal here was to try to project out prevalence, incidence, and direct costs of care associated with diabetic end-stage renal disease over a 25-year time frame to support policy analysis to manage the disease. Support policy analysis in terms of interventions that might lower this burden, either of cost or in terms of the health burden, and also to a certain degree to support planning of dialysis clinic capacity within the province. Dialysis clinics are capital-intensive operations. You need to, build facilities, and particularly with much of the burden of diabetes being felt among First Nations people, many of the needs are in fact in the north, as well as in other remote communities. It's a very sad fact. I didn't emphasize it, but the prevalent cases of diabetes in our First Nations populations are devastatingly high. In women above 55, I believe that in First Nations communities, on average, literally a majority of women have diabetes. This is a very, very high burden that's being suffered by this vulnerable population. And the model was designed particularly with a focus to try to help address this disproportionate burden that is falling on Aboriginal peoples. But we're also interested in understanding the health and cost impacts of interventions that are not only focused on people with diabetic end-stage renal disease, such as peritoneal dialysis, but also focused on those with diabetes but who haven't developed end-stage renal disease yet, but also focused upstream. For example, lowering obesity. How would lowering obesity rates earlier in life lead to by lowering risk of diabetes, to what degree might that lower and bend the curve associated with end-stage renal disease? Remember, I talked about models being very helpful to think about the system-wide, including sort of distal type implications of investments in a particular area of the system. We might invest in obesity reduction, but we can see with a model how that ripples through to end-stage renal disease, how it ripples through to lower burden of diabetes and even lower competition for kidneys among those who have end-stage renal disease. So, for kidney transplant. So, here we're interested in capturing the health and cost impact. We're interested in capturing aspects of individual history, such as family context and their exposure earlier in life, even things like birth weight on interventions, and potentially location as well. So we are interested in capturing this sort of situated context of diabetes, and particularly linking it to other aspects we've studied a lot, such as gestational diabetes. We had a set of data, administrative data, that we are drawing on very heavily, as well as a set of primary data. We also drew on formal competing risks analysis, biostatistical analysis, heavily work that I helped co-supervise with my colleague June Lim over in Community Health and Epi. And we are interested in the ability to compare longitudinal data, which we had from administrative sources, with model results, and to represent resource-constrained processes. Now, I'm throwing a lot of these things in here, partly with an eye towards this group, because from these needs, from these requirements, these goals of the model, you may start to recognize things that will clue you in to some of the techniques we used. For example, if I said I want to represent resource-constrained care processes, what sort of modeling might you think of? What sort of modeling has resources represented as a first-order thing? Anyone remember? Discrete event modeling. If I want to capture longitudinal progression of individuals and aspects of an individual's history in terms of their risk profile, is that something a system dynamics model would give me? No, typically it would require an individual-based model, which could capture episodes of care, but could also capture family context and history. So that might clue me into aspects of motivation for agent-based modeling. So the basic approach that we used for this, and I apologize for going quickly over this, we have a system dynamics model that represents individuals in a sort of more aggregate, rough way, very fast way, for earlier stages of the risk continuum here. Individuals progressing among different levels of risk with respect to weight, progressing on to pre-diabetic status. We use system dynamics to divide people into categories. Now, this is not undifferentiated stock. This stock is actually itself divided into 17 age categories, 2 sexes, and 2 ethnicity groupings. But we have a fairly aggregate model. We're counting the number of people in this rather than capturing individuals. We further, when people flow into this category, are capturing sort of pre-diabetes status. Now, this is a very important point I want to emphasize. And it brings us back to this notion. Remember, with this sort of modeling, with dynamic modeling, we're trying to capture the underlying processes that are out there. And not all the time will those processes have been observed or where we have direct data. So one of the things you might represent in a model like this is the fact that there's some stock. We don't know exactly how large it is, although we can perform screening efforts and other efforts to try to identify it, of undiagnosed pre-diabetic people. There's some group out there of people. We may not have data on them directly, although some of the CAN risks screening has shed light on it, a little bit on it, who are undiagnosed. They're pre-diabetics, but because they're undiagnosed, they're not aware of their condition. They may not be taking care of their diet, their lifestyle investments as well as they could, and therefore they may be at higher risk of developing type 2 diabetes quickly compared to someone who's a diagnosed pre-diabetic. So some of the interventions we were interested in, it was interventions for screening that might help us recognize cases of pre-diabetics who could be diagnosed and therefore managed more effectively. So we want to capture that feature. Now, once people reach this stage of prediabetes, if they then go on to develop type 2 diabetes, we actually turn them into agents. They actually flow out of the stock and they become an agent within the model. And that agent is created with characteristics that are reflective of their age and their sex, etc. In principle, we could place them as Dylan has in his models in a GIS context, etc., to represent urban versus rural based on the characteristics of new diabetics. But each of these people in the agent population is governed, as you might imagine, by state charts, like you've seen. They have individual history information that can track, amongst other things, how long they've been on the waiting list, for how long they've, how many how many appointments do they have to have as part of their assessment process? We can track those sort of things. When did they receive their kidney transplant? Because they're an agent, we can track those aspects of individual history. Now, these individuals, as agents, they can also play a role in a discrete event modeling process to capture their care context, where they are in assessment, where they are in terms of weighting a kidney, where they are in terms of delivery of that kidney from either cadaveric or live sources. Okay. Here we have a system dynamics model. We have an agent-based model and a discrete event model, where these two work with those particularly who are diabetic. And this one up here is specifically for those who are before they're diabetic. So this is why we call it a tripartite modeling architecture. We have all three types of modeling approaches being used, and we'll talk about some of the benefits from this. So let's talk about a little bit about the structure of this model. Here we have a depiction of successive stages of time with diabetes. Individuals, remember, are sort of budded into the model, turned into agents when they become diabetic. So we have individuals who start off with diabetes here, and they progress through this sort of aging chain as they've spent more and more time with diabetes. Now, based on the results of a biostatistical competing risks analysis, we actually had hazard rates, these rates on a per-year basis. What's your chance of developing end-stage renal disease or dying before end-stage renal disease? And once someone developed end-stage renal disease, they would undergo renal replacement therapy. And they'd go either to a dialysis type set of modalities, or they'd be transplanted preemptively. In the most part, they went to dialysis. And having gone to dialysis, they're placed on one of these modes of dialysis, either hemo or peritoneal dialysis. And there's mode switching between those, which is reflective of the fact that sometimes an individual starts on hemo and becomes available for peritoneal, or it goes off of peritoneal because of infection problems and goes on to hemo. So being in this state, they go between these states, and they're accumulating costs all through this process, and they are at risk of mortality. The risks associated with mortality in dialysis are very severe. And as part of this work, we teamed up with CORE, Canadian Organ Replacement Registry, to do a survival analysis looking at people in our province associated with dialysis and the risk of death. And it's a very sobering thing. People typically live on dialysis for 2 to 3 years on average before they die while still on it. Now, some individuals, however, do receive transplant. We'll talk about the workup that's required to allow them to qualify. Once on this, they go through a set of stages which reflect the decreasing costs over time and the decreasing risks of graft failure, of the kidney failing over time while on transplant. Eventually, graft can fail, kidney can fail, and they can return to dialysis. And eventually, they may also pass away with that donated kidney. So here we have individuals tracked as agents in our model with respect to these modalities. Because they are agents, we can ask questions like how long have they been on dialysis, tell me all their encountered types of episodes, with different types of modalities they've been on, how long have they had that kidney, and we can use that information to govern their dynamics. Someone who's had a kidney for longer has a lot less risk of graft failure, for example. So we have this model at the agent level of this, and this is based on a huge amount of data collection that was done by master student Amy Gao as part of her thesis. Now, I don't think I'll go into this in great detail, but we took great pains to link this in with historic data and to match up historic data. In terms of the care process, what we basically captured using the discrete event model was assessment for care. You don't just go immediately onto the waiting list for kidneys for a transplant. Instead, you're worked up by a number of physicians. And both the number of those physicians and the timing of the visits we tried to capture in the model. We further captured this sort of waiting for assessment and the time spent in assessment, I should say. And then we also represented the waiting list for kidneys, including the fact that if you were on the waiting list, you made your way through in a prioritized fashion to the front of that waiting list. But if you were transiently sick, say with the flu or some sort of infection, they would actually defer you. You'd be eligible for a kidney originally, but then you get sick and you're put on hold as far as your ability to get a kidney. And we had two sets of kidneys, kidneys coming from living donor kidneys and kidneys coming from deceased donors. And those were fed into sort of, when someone was ready, not on hold anymore, they'd be placed eligible for the appropriate type of kidney. Now, this sort of structure, although we didn't take great advantage of it here yet, this sort of structure could allow you to examine certain types of interventions that might focus on getting the word out about the importance of contributing kidneys, or having these opt-out programs that are different from Canada's typical opt-in for kidney donation. There are certain countries where, by default, you are a potential kidney donor, but you can opt out of it explicitly. You can opt out of organ donation. And it tends to lead to a huge increase in the number of organs that are available because it requires active choice to opt out. In Canada, where opt-in is the rule, you're not on that list of organ donors unless you explicitly opt in, and many people, just being too busy or not thinking about it much, don't think to do that. So we could examine the impact on flow of kidneys and on transplant rates of having those sort of programs in place. Those are amongst the sort of interventions we looked at. So we had a wide variety of data sources for this. This model is definitely down in that lower right quadrant that we saw, and it was subject of a master's thesis that went on for a few years here on a part-time basis. Amy was working in the IT sector as well at the same time. So there's a variety of types of analyses here, and we are so lucky to have partnered with the renal program here through Joanne Koppel's help, to have some help from the ministry. We talked with Diane Tucker there, and also through cooperation with Canadian Organ Replacement Registry. Okay, I think I'll skip this. We examine hazard rates. Now, what did the model show us? Well, we went through a process of sort of checking the model against results. It involved matching the model up against a variety of sources of data that we had available to us to see how the model results, shown here in red, matched up against the historic data. And without going to it in great detail, in time series after time series, we found the model matched pretty well. When it didn't match well, this is an example of where it was a little bit off. There were multiple time series which themselves disagreed about what the number should be. But we spent quite a bit of time sweating these sort of details. Is there a good explanation for why it's off? Did they change the definition of the data collected? What does the data collected not pay attention to? Spent a variety of time tracing that and trying to make sense. So this is the result again. This is a hybrid model, so agent-based modeling, discrete event modeling, they're stochastics. So different model runs will give different results here. And so there's a spread in the model showing sort of what the model thinks these numbers would be as of this year. So we ran it over the historic years to develop confidence in the model before running it forwards, and spent quite a lot amount of time sort of refining that. We used a variety of longitudinal data as well, such as median days on dialysis prior to transplant, as well as things like the waiting list head count. Okay, so having developed some confidence in this model, we then sought to use it to look forward. And one of the things we're looking at is over both historic timeframes and later timeframes, what would we expect to see in terms of sort of prevalent case count using 1980 as a base. And we did this for First Nations people who are at higher risk, as well as non-First Nations people, and in totals shown in black there. And what you can see is the prevalent case counts, both because of rising rates of diabetes as well as high rates of end-stage renal disease, are large. And we projected costs as drawn from studies by Hemmelgarn and Braden Mann's group in Alberta. We had costs associated with different stages of end-stage renal disease and diabetes that we plugged in to get cost estimates over time. And as you can see, these costs on a per-year basis are very sobering. They rise very significantly over time. We looked at accumulated cost, which runs into, soberingly again, the billions of dollars, and life years lived, which helps us clue us into kind of effects, among other things, of lowering mortality rate. Okay, so we examined a variety of scenarios with this model that were aimed at sort of what-if questions. Some of these were focused on intervention probabilities or possibilities, but a lot of them were focused on sort of scenarios we could imagine working towards, although maybe not reaching, but we were interested in how far they could get us. So, for example, if you could have all preemptive transplant, the dream of centuries, if you, at the time, someone develops end-stage renal disease, if we had a kidney available to them, grown in a lab, how much would that help? How much would it help to put everyone on hemodialysis or all on peritoneal dialysis, cost and health trade-offs? How if we had no diabetes after 2005? Look at a little bit retrospectively, how would that affect things? We actually looked at some other ones I won't have time to go over, but I'd be glad to share the slide deck with you. So, for example, here's an impact of preemptive transplant. We preemptively transplant individuals, and we're assuming that this starts early on here. What if we had started a preemptive transplants? How much would that lower the burden? Well, in terms of diabetic end-stage renal disease cases, it would actually raise the number of cases. We're keeping people alive for longer. That's a good thing. It raises the prevalence, but it's because we're saving people's lives who otherwise would have died. We have more people to care for, but they're alive rather than having passed away. And it causes more person years lived. But interestingly, ladies and gentlemen, it lowers the costs. It lowers the cost. Even though we have more cases of diabetic end-stage renal disease, the cost is a lot less because they're not, in fact, on dialysis. They're on this eventually cheaper effect of transplants, and it lowers the accumulated costs associatedly. Suppose we were to put people on hemodialysis only as the initial treatment rather than both hemo and peritoneal dialysis. Well, you can see that you might have thought this would be a really big effect, but actually the effects are fairly limited. There is a somewhat higher cost associated with it and a somewhat lower prevalent case count here, but the effects are comparatively small. Modality change has a fairly limited effects. How if they received peritoneal dialysis? Well, we actually save people's lives here, and we actually lower costs. So this is actually a case where we've actually managed to save people and bend the curve in terms of costs, somewhat significantly. Suppose we could stop all diabetes from 2005 onwards. You might think that's a magical treatment. It's, the dream of the medical establishment. Stop incident cases of diabetes, 2005. So to guide you here, that's about here. And what you see is again, sobering. What you see is that even if you were to cure diabetes in the sense of stopping all new cases in 2005, the number of diabetic end-stage renal disease prevalent cases continues to rise. Why does it continue to rise? Anyone? How would it still go up if we're stopping all new cases of diabetes? Current cases still are there, and they're going to be developing end-stage renal disease. So the peak in the number of end-stage renal disease patients doesn't peak in 2005. It continues up and up and up till right around 2020 or so. Equally sobering, the costs are also rising well after that and peak only around the same time, roughly. The accumulated cost starts to be lowered compared to the baseline, but it takes a long time for it to become a big gap. So what this is saying is, we and the patients are going to be grappling with this burden of end-stage renal disease for a long time. Even if we had magically successful treatment on the diabetic front, this is a very serious issue. Cost-wise, it's a very serious issue in terms of the health burden, and we have to come to grips with it. Remember I said earlier that models are sometimes used to kind of cross-check grand claims being made, let's invest in this, let's lower the rates of diabetic end-stage renal disease by 20% by year, 2020. Sounds like a great scheme, but this is a sobering reality that, even if we were to cure diabetes, we wouldn't be able to lower it by 20% by year 2020. We have to be realistic so we don't put in a position to have a big fall. We want to set our expectations so we're not under this burden, so we can channel our energy into things that are achievable, things that really make a difference. And what this is telling us is that that's like King Canute ordering back the tide. Stop tide, do not advance. It's not going to be very effective. We might as well channel our efforts in our inspirations into things that are achievable. What if we could, have mortality hazards for dialysis patients? Well, it can have a tremendous increase associated with, so if you can manage these patients much more effectively, leveraging, for example, modeling results from our colleague Jim Rogers at Mayo, showing amazing model-based insights that can simultaneously lower the cost, lower the mortality risk, and enhance the quality of life for dialysis patients and lower the burden on the physicians. Amazing results instigated by working with a model. If you could realize that, you could have the rates associated with mortality rates associated with dialysis, grand success, but you're going to be dealing with cost implications that remain very sobering. It's going to really increase the number of individuals who are living with end-stage renal disease. That's a good thing. They're living. That's great. But cost-wise, we need to be prepared to bear with that. The costs are still soberingly high. Now, as I said, this modeling framework puts in place the ability to examine a wide variety of interventions, screening interventions, obesity reduction interventions. And I apologize, I don't have time to go over all the scenarios, but it gives you some ideas of the sort of things you can do with a model like this. It also, I hope, will highlight for you this fact that when I say models exhibit regularities, there's some uncertainties, but there's some regularities. These bars here are showing the level of variability run to run. And you can see, there's some uncertainty given the model structure, but, the patterns are pretty clear. It's not, this doesn't loop around or just go crazily wide. It's pretty clear what the implications are. It's just there's some variability seen. Okay, so this is very much still work in progress. This tripartite model, the final version of it was created last year. We have work right now going on writing this up for clinical audiences, but we do have some papers out that describe the model. If anyone's interested, I'm glad to refer you to more details on it. I will share these slides if you're interested. Okay, so that was a little case study. Any questions about that before I move on to a really quick hit on the issue of models and big data? Questions? Okay. I should note that that model, if anyone's interested and is going to stay here the next 2 days, I'd be glad to let you browse through this model, this diabetic end-stage renal disease model. It's an interesting model to explore. You'll find lots of features in it, and I could help point out to you the significance of some of those features. I mentioned to one of the attendees here that you can't run it directly because it depends on a database to read in, I think, incident cases of diabetes over time for historic data from back to the 1980s. And so it needs a little bit of pointers in order to get it to run. But I could potentially work with you to at least show you how it works and the basic mechanisms by which it's designed. Okay, so